hereby I open this academic ceremony in which Sheizi Prista Sari will defend the academic thesis Pressure Injuries in Indonesian Community Dwelling Older Adults, Prevalence, Prevention and Treatment by the Informal Support System. May I invite you to present a summary of your study and the conclusions of your thesis.
Dear Prorector, the members of Corona, supervisors, the Ambassador of the Republic of Indonesia, represented by the Attaché of Education and Sociocultural, colleagues, friends, and families. In the next 15 minutes, I'd like to present the summary of my dissertation entitled Pressure Injuries in Indonesian Community Dwelling Older Adults, Prevalence, Prevention, and Treatment by Formal and Informal Support System. To begin with, I would like explain pressure injuries. A pressure injury is a localized damage to the skin and or underlying tissue, usually occurring over a bony prominence due to prolonged pressure or pressure combined with shear. Pressure injury can be categorized into 6 categories: Category 1 to 4, unstageable and suspected deep tissue injury. Higher categories indicates more severe damage to the skin. Pressure injury category 1 and 2 are known as superficial or preventable pressure injury. Pressure injury affect patient quality of life, emotionally, physically, socially, and even put patient at an increased risk of death. In addition, pressure injury represents a substantial financial burden on healthcare system. Therefore, pressure injury is generally considered as an indicator of quality of care in healthcare services. The occurrence of pressure injury worldwide varies. A systematic meta-analysis study in 2020 reported that pressure injuries still affect 1 in 10 adult patients admitted to hospitals. And from the study, they highlight that mostly affected older adults. Older adults may be at high risk of pressure injury because the aging process leads to physical impairment and associated immobility, and the skin can be more vulnerable to damage. Furthermore, the study also highlights that older adults suffer from pressure injury before hospital admission, meaning that they suffer from pressure injury even before hospital admission in the community. So community dwelling older adults are at risk of pressure injuries. However, from the study, data were collected from people receiving healthcare services. Now, turning our attention to the situation in Indonesia. Indonesia is a country in Southeast Asia. As many countries, Indonesia is experiencing aging population. Around 26 million of its people are older adults. And the study took place in Bandung City, which is the capital city of the most populous province in Indonesia. The majority of older adults in Indonesia live together with their family members. As response for the aging population, Indonesian government issued some regulation regarding healthcare and welfare for older adults, including healthcare insurance. As many countries, chronic disease is increasingly significant in Indonesia, but unfortunately, older adults in Indonesia often do not access formal care. Reasons vary. They prefer to self-medicate or cultural factor. They have no clue when to access healthcare services, or the cost of treatment or transportation because of nobody to accompany them, or only for the reason for long waiting time. Consequently, they only receive care provided by family member, or they only rely on informal healthcare services. However, inappropriate care or support for this vulnerable population could lead to adverse events such as pressure injury. In fact, studies in Indonesian hospitals show that the majority patients who suffered from pressure injury before hospital admission were older adults living at home, and none of them received professional home care services before hospital admission. Based on the explanation above, we can hypothesize that a high prevalent rate of pressure injury among Indonesian older adults. This assumption, based on the fact the aging of the population and increase of chronic disease associated with pressure injuries, older adults usually only rely on informal caregivers, and the high number of pre-existing pressure injuries in hospital. However, how big the problem is still unknown because no study is available involving older adults living at home in Indonesia. Therefore, this dissertation aims to explore the magnitude problem of pressure injuries in Indonesian community dwelling older adults following the ecological environment model. Because the problem exists in the community, and in many cases, pressure injury problem occur among adult adults, which is avoidable, so PI prevention should become a focus of activities. First, we should investigate the occurrence of pressure injury in the general population, irrespective of whether or not they access formal healthcare services. Second, because family caregivers have a large role in taking care of older relatives in Indonesia, their knowledge, attitude, and practice about pressure injury prevention should be explored. Third, community nurses as formal caregivers in Indonesia as a primary care provider who have responsibility to address the problem among older adults in their working area. So the study should be conducted to explore knowledge, attitude, and skill community nurses regarding pressure injury prevention. In addition, there are perceived barriers and potential facilitators about the pressure injury prevention and treatment at home should be more explored to get the deep insight about the problem. For these purposes, 5 studies were conducted. Study 1 aimed to explore the prevalence of pressure injury in community dwelling older adults in Indonesia. The data were collected by directly visiting the participants in their houses. 325 older adults in Bandung City that represent all sub-districts in Bandung City participated in this study. The result showed that the prevalent rates of pressure injury among Indonesian community dwelling older adults of 10.8%. Based on this number, we can predict that around 11,000 to 32,000 older adults in Bandung City are suffering from pressure injury at home. And the risk factors that strongly correlated with the problem are physical activity, sensory perception, and stroke history. None of the participants who suffered from pressure injury at the time received one care or information about PIs from formal caregivers, and only 11% of them received one care from family caregivers. Study 2. Due to the lack of an instrument to assess knowledge, attitude, and practice of family caregivers about pressure injury, we conducted Study 2, focused on the instrument development and evaluation. 3 phases of instrument development and evaluation were used, including item generation, instrument construction, and psychometric testing. In total, 372 family caregivers were involved in the study. The study resulted in CAPI instrument, an instrument that can be used to assess family caregiver knowledge, attitude, and practice, consisting 12-item domain knowledge, 9-item domain attitude, and 12-item domain practice. All the items in the CAPI instrument have Kron-Bahava above 0.8, meaning that the instrument seems to be reliable and valid. After developing CAPI instrument, we use this instrument to directly assess knowledge, attitude, and practice of family caregivers on pressure injury prevention. 267 family caregivers participated in this study. Based on this study, we can see that more than half of family caregivers had insufficient knowledge about PI prevention. For example, only 30% of them knew the definition and symptom of pressure injuries. But they have positive attitude. They agreed that helping their older relative is their responsibility. But still, 41% of them had inadequate practice on PI prevention. For example, some family caregivers stated that they never help in repositioning their older relative who have problem in mobility. Repositioning is a crucial activity to prevent pressure injury. Now, I would explain my point on the study involving community nurses. Study 4 aimed to explore knowledge and attitude of community nurses on pressure injury prevention. 235 community nurses permanently working in the primary healthcare, or namely Puskesmas in Indonesia, participated in this study. The results show that mean knowledge score 30.7%, meaning that community nurses also had insufficient knowledge about pressure injury prevention and treatment. For example, only 14% of them understood how repositioning prevents pressure injuries. But they also have positive attitude toward PI prevention. They agree that PI prevention is a greater priority than PI treatment. The last study is to explore what community nurses perceive about barriers and facilitators in PI prevention at home. A mixed method study was chosen, quantitative study using questionnaire, followed by qualitative study through focus group interview. The results show that community nurses explain that they experience barriers in PI prevention and treatment among Indonesian community dwelling older adults, including lack of time, inadequate equipment, limited opportunities for training, inadequate knowledge and skills, and lack of actual data about community dwelling older adults. They assume that refreshing their knowledge and skill, strengthen the policies, and intense collaboration with formal caregiver could be strong facilitator to improve their role in PI prevention. In conclusion, we can see that the magnitude of problem of pressure injury among Indonesian community dwelling older adults is a serious problem. The fact that the PI prevalence rate was 11%, and they have insufficient support from formal and informal caregivers. Family caregivers lack knowledge on practice on PI prevention. Community nurses also lack knowledge and practice on PI prevention, and community nurses experience several barriers in performing PI care, and they need facilitators to improve their practice in PI prevention and treatment. Therefore, some recommendation from our study: we should strengthen the role of the support system, community nurses, and family caregiver. And also, we see that there is an important role from volunteer who can be a facilitator between formal caregiver and informal caregiver. We recommend training that can improve community nurses' knowledge and skill regarding pressure injury prevention and treatment, as well as we recommend training and education program to improve family caregiver role in taking care of their older relative to prevent PI prevention. However, we should also see the regulation is important part to solve the problem, and the Ministry of Health should clarify the role of and responsibility of community nurses so they have enough time to do this kind of job. However, future research should be conducted regarding appropriate education program, educational material, and practice support, and also maybe a feasible model that can be solved comprehensively the problem. Lastly, I show you again a picture of pressure injury. This is a pressure injury grade 4, but this pressure injury was suffered by my brother. He was diagnosed for cancer stadium 4, and he lost his capability to move. he even suffered from pressure injury than cancer itself in the last 6 months of his life. I educated his wife to prevent the problem, and I also support him with a special mattress, but the problem still exists. My point is, pressure injury prevention in the community is challenging, even among younger people. So pressure injury in community-dwelling older adults requires serious attention and a comprehensive, collaborative, multifaceted approach to be solved. And we hope that our study can increase awareness about the problem in the community, not only for Indonesia, but also for other countries who face the same challenge with Indonesia. Thank you for your attention. I give back the word to the prolector.
Thank you for your presentation. The opposition will now be opened by Professor Zwakhalen. She's a professor of nursing science at this university, and she was also the chair of the assessment committee.
Thank you. And dear candidate, thank you for your wonderful work. I think you again showed us how relevant your work is. For practice, for society, but also for personal suffering. And I think, thank you for trusting and for taking us with us to your impressive work and story, which is behind it. And also the personal touch is within the cover. I really loved it, so thank you for that. And also, of course, to your supervision team, congratulations on this wonderful work. But I'm not only here to, to express my gratitude and about your work. So I want to ask you a question as well. And I would like to, you made it very clear. You revealed that pressure injuries is indeed a problem that needs attention. And also, the prevalence rates that you come up with around 10%, but also, the knowledge shortage that you demonstrated revealed that at least the problem requires attention. And while I was reading your thesis, I wondered, and you, of course, I know you didn't research that, but you, as you know, pressure injuries is part of the LPC, which also addresses other care problems. And when I was reading it, I was just really wondering whether your findings, the knowledge shortage, the prevalences, would be really different for other care problems that were in the LPC. So how, the findings that you have, how specific are they for pressure injuries, or would they also account, especially the knowledge shortage, for other care problems? Would you like to start with that? And then I will continue with my question.
Yeah. Dear highly esteemed opponent, thank you for your compliment and also for your questions. Yeah, pressure injury is kind of, we can put this problem as an indicator that can represent many problems related to the healthcare services, not only in community, I think, but also in the hospital. But this pressure injury, why it's a kind of specific for Indonesian community dwelling older adults, because in Indonesia, community nurses should supervise a kind of large of area, and then they should supervise many older adults living in their working area. So maybe if we if I'm not mistaken, your question, how relevant this problem can be also a problem in the another healthcare system?
Yeah, I just wondered if, for example, you look at other indicators which are in the LPC, for example, incontinence or malnutrition. Do you expect that you would also find these knowledge shortages, or at least that it's prevalent? So how unique are your findings related to this specific care problem, or would they also probably cure for others, which is my expectation, but I'm not sure. Of course, that's what I ask. So
I can clear the question. Pressure injury only one indicator, and then we believe that if we also measure or assess the other problem, we are in the indicator in LPZ program or LPZ quality of care in LPZ, we will maybe also find a high number, because the risk factor for the problems, for example, for the incontinence, the risk factor in Indonesia also high. So if we studied about this problem, I believe that among Indonesian community dwelling older adult, we also will find the high prevalence of incontinence, and also the problem with the, but yeah, maybe two indicators for me is pressure injury and incontinence. It could be related, but I'm not sure with the other indicator. For example, for nutrition status, because in the community it's a bit different situation about nutrition status. And when we conducted our study to measure nutrition status, one of the indicator for the LPZ, and it's quite difficult because we cannot exactly measure how much they eat every day and how many portions they eat every day. So I think, but it's still relevant.
Okay.
Yeah.
I just want to interrupt you, because I think what we agree upon is that these indicators might link to each other, that they might relate to each other. So, and I'm always not in favor of focusing on one care problem, because I do think that they are in relationship to each other. And so perhaps we need a more integrated approach in which we come up with a solution for this knowledge shortages, what may be there in other indicators. Yeah. Do you agree with me that we need more an integrated approach?
Yes, I totally agree with you. Yeah.
Okay. I look at the prorector if there is, there is a bit more time. So then you're still stuck with me. Yeah. So we continue to, I would like to ask you another question about a different chapter, chapter 3, in which you evaluate the psychometric properties of the instruments. And you've, you developed an instrument, and you, assess the construct validity as well as the internal consistency. And I just heard it also in your presentation. If you look at what you evaluated, I'm not fully in agreeing that it's reliability that you investigated, because internal consistency is more about the homogeneity of a scale, but I may have missed it. So can you help me on what elements of reliability you assessed?
Yeah. Thank you for the question again. Yeah, for the reliability, what we did in our study, because there are many ways to measure the reliability, and the most important point from the reliability, we can assess the same thing in the different time. And what we did in our study, we conducted 2 data collection in the different time, and then we based on the literature that we read at the time, it can be approved as long as we can reach the appropriate number of participants and the appropriate number of data collection, and then we can use Cronbach alpha as an indicator for the reliability. So what we did in our study, we collected data for the sufficient number of participants in 2 different times, and then we compare the result, and then we get the Cronbach alpha value of above 0.8.
Okay. For now, I'm satisfied with the answer, and I give the word back to the prorector.
Thank you.
Thank you. The opposition will now be continued by Dr. Harun. She is a doctor in nursing at the Maastricht University in Indonesia, and a special word of welcome. Thank you for joining this ceremony on site with us.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. First of all, I want to, I'm a dear candidate, sorry. First of all, I want to appreciate and for giving me an opportunity to read this beautiful and excellent work of yours. And I know that this is the first study about the pressure ulcer incidents in Indonesia. And this is very important. I have enjoyed reading this result, but I want some insight from the candidate about the candidate planning after finishing this PhD. From your result, what is your planning to advocate this important finding, this evidence to the government? Because when we say about the when we say about the about the prevention and promotion for the pressure injury in older people, it should be integrated also in the long-term care policy, in whether in the hospital or in the community. So how is your planning to advocate into the policymaker, at least in the sub-district or district health office in, not district, provincial health office in Bandung? Thank you.
Dear esteemed opponent, thank you for the kind words and also for the questions. It's a challenging question because we face many challenging how to sound our result to the government or to the policymakers. First, to talk or to communicate with the policymakers, of course, we need data. Of course, we need scientific data, and we believe that our study can be a scientific data, can be evidence that can speak loudly than our voice to raise the problem, to raise the awareness of policymakers regarding prevention and promotion, especially in Indonesia, because we still face three burden of disease. We still fighting with the communicable disease, we are fighting with the chronic disease, and also we are fighting with the new emerging disease. So it's kind of difficult to make a program or a prevention promotion program to be a priority for the government. But we believe that with this evidence and in collaboration with nurse associations and also with academic personnel, for example, we can speak confidence, because the fact is here, and then we should do something with this problem, because older adults are older adult is a future for everyone. So we should prefer a better life support for all of them, for all of us in Indonesia, I think. So first, we should collaboration, of course, and then we will present this result in front of the policymakers.
Yeah, I think the integration of into the healthcare system is really important, especially when we talk about the lack of the time of the nurses doing the care for other people in their homes, and especially also lack of resources. So how those things funds? What do you think about that?
Yeah, thank you. I totally agree with you, because community nurses cannot do this work by themselves. They should integrate the program, because if community nurses, for example, in study 5, they explained that they have limited time to do their own professional job. For example, to come to the community to visit older adults at home, because they are too busy with their tasks inside the building of primary health care. And some of the tasks that they perform inside the building, that's not really their own job. So with the integration program among healthcare provider, healthcare professional, we believe that community nurses can take time and can take opportunity to do their own responsibility in their working area.
That's excellent. Okay. One more thing, a small thing, also about your planning. The candidates planning, because I believe that working in the community, doing this very huge and excellent job is very challenging, and maybe the candidates found lots of barrier. So how is your experience working and research in this specific context in Indonesian community? How your experience will enhance your future career, your future research, and how to lecture to our students later? Thank you.
Yeah, thank you for the question, because it reminds me to go back to Indonesia after this study. And first of all, of course, I'm lucky because I have a perfect supervisor team, and then they teach me everything, many things, a lot of things to be a good writer, to be a good researcher. And the important thing that I learned before offering a program or before offering a solution, we should see the problem clearer. So my experience during my PhD journey is kind of sharpen my experience to see the problem, and then after we can see the problem clearly, so we can offer some solution. So when I go back to Indonesia and become again a lecturer in Faculty of Nursing, Pajajaran University, first, I should learn again about the real current situation, because I left already 4 years Indonesian, and maybe it's kind of different situation in Indonesia right now, but I believe that my experience in Maastricht University can be shared to colleagues and also for my students and also for community nurses maybe in Indonesia, so we can work together to improve the quality of care, especially in my specific in community setting.
Excellent, thank you.
Okay, thank you. The opposition will now be continued by Professor Dr. Kottner. Also, special word of welcome to you for joining us on site. Professor Kottner is a professor of nursing science at the Charité University of Medicine in Berlin, and he was also a member of the assessment committee. Professor Kottner.
Thank you very much. Dear candidate, thank you for the excellent presentation and the very interesting results. So I also really enjoyed reading your thesis. So I would like to start with a question regarding the questionnaire you developed for informal caregivers or for relatives or family members. So my first very short question is this questionnaire or the standardized instrument you developed, is this specific for the Indonesian population?
Dear highly esteemed opponent, thank you for kind words and also for the questions. First of all, KP instrument is kind of a big job for us actually, for me especially, because it requires many participants and also a statistic job. But we believe that KP instruments is not only for family caregivers in Indonesia, but also for other countries who probably have the same characteristic of family caregivers or informal caregivers, because in Indonesia, informal caregivers are mostly family members. And then we believe that in other countries, for example, countries in Asia also rely on family members, so it can be used as well. And also this KP instrument also can be used among volunteers in Indonesia, and if other countries also have volunteers who have non-degree educational background about the health services, we can also use this KP instrument to assess their knowledge, attitude, and practice, because questions in the KP instrument are basic questions that they should knowledgeable about the problem. For example, question about definition, symptom, and how to prevent the problem in the way that they can perform at home. So we believe that it can be used also in other countries.
So thank you very much. Just in case you would like to use it, what would be the next steps then? So what would you do if a colleague approaches you, let's say from Asia, and say, may I use it? So what would you recommend? How to proceed from here?
Yeah, thank you. We published already the instrument in the international publication, so we believe that colleagues, friends, or any researcher from other country can directly access the instrument and they can use. And we also, hopefully in a little while, we will publish another study regarding the use of copy instrument in our study, in study 4. So colleagues, friends can see how we interpret the data, and also they can use the cutoff point, how to assume that a family has insufficient or sufficient knowledge about the problem. And of course, still copy instrument need to be improved, of course. I really agree if colleagues or friends from other countries use this copy instrument, and then we can communicate each other, and then we can improve the quality of the instrument, and maybe incomprehensively, or maybe in the term of words used in the instrument.
Thank you very much. May I have a follow-up question then? So you just mentioned a cutoff. And I always ask myself when using, let's say, knowledge instruments, is a cutoff really useful? So you said whether someone has sufficient or insufficient knowledge. So I do understand the principle, but isn't it more, let's say, a range from from poor, weak knowledge to, let's say, excellent knowledge? So I ask myself, if someone really met the threshold, is this sufficient to assume that he or she knows enough?
Yeah, highly esteemed opponent, thank you again for the question. We decided the cutoff point for copy instrument, especially for knowledge domain, based on the analysis of the point in the instruments. So in the knowledge instrument, we only have 12 items, which are the basic question about the problem. So we put a bit high of cutoff point. We put it 70% to be called sufficient knowledge about PI prevention, because from 12 items, there are questions that family caregivers or informal caregivers should know about the problem. For example, definition, symptom, it's difficult to teach them the problem, to teach them about the practice if they do not know about the definition, symptoms. So it's kind of basic questions. So cutoff point is decided based on the analysis point of in the instruments.
For me, it's rather found then that you have key items, so the must-known things, and maybe there are some things that are less important. So maybe this is something to consider for the future.
Thank you.
Thank you very much, Professor Kortner. The opposition will now be continued by Professor Milena Pavlova, and she is a professor of health economics and equity at Maastricht University, and she was also a member of the assessment committee.
Dear candidate, my congratulations to you and to your supervisory team for this important dissertation. You have investigated a highly relevant topic, and evidence that are provided by your dissertation can inform decision makers and practitioners on how to address the problem of pressure injuries among older adults, specifically in Indonesia. This research topic has already captured the attention worldwide, and your dissertation for Indonesia in particular is very much welcome. In your dissertation, you have presented insightful studies, mostly quantitative with some qualitative elements, which means that you have mastered many different research methods. And publication of the dissertation chapters in respectful journals also demonstrates the quality of your dissertation. I would like to discuss with you chapter 6. In this chapter, you study barriers and facilitators to pressure injury, prevention and treatment among older adults living at home. And you use a mixed method approach.
Yeah.
Now, the mixed method approach always raises a lot of questions. So, could you please explain why the mixed method approach was used in this specific study? And is this a truly mixed method approach or a mixture of methods? So when is a study a real mixed method study, and why you think that your study is such mixed method study? Could you please clarify?
Yeah, dear highly esteemed opponent, thank you for your compliments and questions. In the study 5, we conducted a mixed method study to get more insight about, to get deep insight about the problem of pressure injury prevention based on the perception of community nurses in Indonesia. What we did in our study, first we used questionnaire. By a quantitative approach, we use questionnaire, and the study involved all the community nurses in Bandung City at the time who were permanently working in public healthcare services. And then from the questionnaire, we got the point. We asked them to choose 3 from 10 list points about barriers and facilitators, and then they have to choose the 3 most barriers or facilitator based on their experience. And from the quantitative study, we got the result that we have list of barriers and facilitator based on the priority, based on the community nurses perception. So we have the priority. And after that, we choose community nurses to participate in our study, and then we to discuss more about the point that they have chosen. So we believe it is kind of mixed methods, because the second study, which was the qualitative approach, is another process after we collect point from the quantitative approach. Yeah.
Yeah, thank you. Indeed, the mixed methods study requires that there is some kind of synergy at some point of time between the 2 methods, and I'm glad to see that you have realized that. Now let's look a little bit at the outcomes of this study, because I was a bit puzzled. In the abstract, you state that availability of data is perceived as a facilitator according to the community nurses. So I was expecting to see that there is no problem with data availability. While I was reading the chapter, I figured out that there are still a lot of problems. So I was wondering, to what extent is data availability facilitator, or is it a barrier? Or maybe some data is available, other is not available. So could you please clarify, is it a facilitator or barrier? What structural problems are there, if it is a barrier, and are they really possible solutions, or this is just part of the context? Thank you.
Yeah. For the facilitator, why we write that it's a kind of potential facilitators, because community nurses haven't got the point. For example, the opportunity for training, they assume that it's kind of facilitators because it's related to their need to improve their role in PI prevention. So a potential facilitator in this case, we believe it's a facilitators, but in the same time, the facilitator is rise from the big barrier that they experience. So it's kind of, sometimes it's difficult to judge it's a facilitator or barriers. But what we learn from our study, community nurses need some facilitator to improve the role. So that's why we believe it's kind of facilitator, because it represent their need about the role to strengthen the role. For example, they say that policymaker regulation, they believe if the regulation can work to make them have a lot of time or their own time to do their job, so it's kind of a good facilitator to for them to do the PI prevention at home. So yeah, we assume it is kind of facilitator.
Okay, thank you. I understand now better. So there is still a lot to be done in that direction. And finally, I was wondering about the possible collaboration between the nurses and family caregivers. I have also mentioned that in the presentation that you say the family members, they lack knowledge, they are enthusiastic. I was wondering, is it possible to have some kind of collaboration, effective collaboration between nurses and family caregivers, given the lack of knowledge among caregivers? And I would expect some possible differences in subcultures between nurses and caregivers. How do you see that? Is that possible to be realized in Indonesia, and what should be done? Thank you.
Thank you for the question. Based on the Indonesian situation, and also based on the theory of community nursing and also family nursing, it should be a strong collaboration between community nurses and family caregivers, because it's different case. If a nurse have a patient in hospital, they can see patient directly all the time. But if we talk about the community, it's not possible for community nurses work themselves, because they need family caregivers who taking care all the adults at the home, and they only can supervise in several time and in exact time, and therefore they need to educate family caregiver as a kind of team from the community nurses, so community nurses can be a supervisor for the family caregivers, and they can educate family caregivers to prevent pressure injury at home, and in the certain time they can come to home and educate again and supervise and to see, because it's kind of long relationship between community nurses and family caregivers, because there is no termination time between community nurses and family caregivers. The family and all the adults live at the community, and community nurses working together all the time in the community, so it's kind of long relationship. So they should be work together, and then community nurses strengthen the community nurses' role will strengthen family caregivers. We believe that.
Yeah, thank you very much. I have no further questions.
Thank you. So the opposition will now be continued by Professor De Bie. He's a professor of physiotherapy research at this university, member of the assessment committee, and the secretary of the degree committee.
Thank you. Dear candidate, congratulations with a beautiful piece of work. Not only the content is very worthwhile to read, but also the artwork introducing each chapter is fantastic. Thank you very much for that. And also compliments on the large number of participants and completeness of your follow-up. Truly, truly exceptional. Also congratulations to your team, which I think gave true to your motto, also their best to make this work a success. It's also especially nice to again meet one of your co-supervisors, Dr. Amir, who did her PhD in 2015, at this university on pressure ulcers in Indonesian hospitals. And you feel a rhythm coming, right? In 7 years' time, she is a professor, you are a co-promoter, and I will come back and ask a question. So the rhythm continues. Now, my first question is one probably of general ignorance. In the days of Dr. Amir, we talked about pressure ulcers. You consistently talk about pressure injuries, and in the introduction you state that pressure ulcers are nowadays considered an old-fashioned term. But when I look closely at the definition and at the stages, I see no difference. So can you help an old-fashioned professor understand why pressure ulcer injuries is now a better term than pressure ulcers?
Dear highly esteemed opponent, thank you for your compliments and also for the challenging question. Pressure ulcer become pressure injuries. It's kind of work from the panel of pressure injury advisory panels worldwide. So what I read from the literature and from the guideline, why the term pressure ulcer become pressure injury, because ulcer mostly be assumed as ulcer or wound. It's kind of open wound, but in the case of pressure injury, sometimes it's not always open wound. It's sometimes it's a pressure injury category 1 and 2. It's not open wound, and also untouchable and suspected deep tissue injury are also not an open wound. So based on the discussion and the discussion and about among the experts in this area, that's why the term pressure ulcers become pressure injuries.
Okay, thank you very much. This leads up to my next question. Because pressure injuries, it's better to prevent them than to cure them, right?
Yeah,
and,
agree.
And especially the first stages are very hard to detect.
Yeah.
Now, in chapter 2, you give details about PI prevalence, and you also showed it in your slides, that you say the prevalence of around 10%, 11%. Now, I remember from Dr. Amir's thesis that in hospitals there was a prevalence of around 30%. That's a big difference, especially when somewhere in her thesis, but also in your thesis, I read that people bring pressure ulcers to the hospital. Now, there's a miracle happening, right?
Yeah.
Given 7 years back, and now your prevalence has dropped 20%. What happened? Or did you, by instance, pick a population that was rather okay or had enough help, although I saw from your slides that nurses don't do anything and family members only do something in 10% of the case. So was your population comparable to the population of Dr. Amir's, or did really prevalence and incidence of pressure ulcers drop in the general population? So can you help me a bit with that?
Yeah. Thank you. What I learned from the Dr. Amir research or studies, she studied pressure ulcer in hospital. In one of her study, he studied pressure ulcer in stroke hospital, which are one of the high risk factor for pressure ulcers in Indonesia. And we know that in Indonesia, what I presented before, older adults in Indonesia often do not access formal care. So maybe if all of them, they prefer to stay home, maybe until they really already give up with the situation, and then they go to the hospital for some cases. I won't say that it's all older adults, but for some cases or for many cases, it's kind of normal for Indonesian people. If the older adults just stay home, it's older disease, so you don't need to go to the hospital. So if we compare the result for the prevalence in hospital, they are already in the situation they have risk factors, for example, a stroke or the immobility, associated immobility. And in the community, we talk about large population. So for example, in Bandung, even though we only find the number 11%, it's kind of a big number rather than a bigger number compared to the prevalence in some hospital worldwide. And then if we calculate with the number of population in Bandung city or Indonesia, it's around 11,000 to 30,000 older adults are suffering for this problem, meaning that they are suffer from some disease, maybe physical impairment or associated immobility, but their family caregivers decide just to take care them home. But one of my quote in my dissertation, caring for older adults requires knowledge and skill rather than only the willingness to take care for them. So it should be aware by family caregivers if they want to take care of their older relative at home, they should have knowledge, they should have skill to prevent such kind of the adverse events. So I believe if Indonesian older adults have a more positive attitude toward health-seeking behavior, we will find a even higher number of PI prevalence in hospital.
Okay. Well, given the time, I have lots more questions, but I won't do that. So thank you very much for your insights, and I give the word back to the prorector.
Thank you. The opposition will be continued by the third guest of opponent, actually. That's Dr. Nijens. And Dr. Nijens is a manager and a senior researcher at the Expertise Center of Wound Care. And thank you very much for joining us.
Thank you, Prorector. Dear candidate, Sheizi Prista Sari, many congratulations also to your team. with the execution of the different studies on an interesting topic and presented in your dissertation. You have done a lot of work, both in the field and also at the office. I compliment you with that. I'm impressed. The aims and the outline of your dissertation are very clear, well chosen and structured, and the results deserve to be disseminated. I would like to focus on chapter 2. Throughout your dissertation, you use an international definition of pressure injuries, and one part of that definition is pressure, prolonged pressure, or the combined pressure. That's important. But then when I look at table 1, when you present the prevalence scores, category 1 is the highest, 61.4%. And remarkable are the scores of the knees and the toes. First I thought that's a lying position and prone position, but that's not the case. And we rarely find these scores in other studies. So I have some questions, and also in the study limitation, you state that the measurement of that category 1 could be biased. And you say probably due to prayer marks. My question is, why is that? Can you explain that a little more, why that could be a bias?
Yeah. Dear esteemed opponent, thank you for your compliments and also for your questions. Why pressure injury category 1 is kind of biased in this study? Because in Indonesia, mostly people have a kind of dark skin. And then it's challenging not only for Indonesian researcher, but also for researcher from other countries who should work with people with a kind of a bit dark skin to measure the pressure injury category 1. But to deal with this problem, we try to use transparent strip to make it clear, to make it to differentiate. Is it really pressure injury category 1, or it's only branchable enema, branchable injury? So a transparent strip at the time is really helpful for our study. Yeah, and.
Yes. I understand that, but I'm troubled with definition, meaning pressure, the pressure on the knees, the pressure on the toes. Is that another kind of pressure than the one you use in the definition of the pressure injuries?
Yeah.
And category 1 is about the non-blanchable erythema. You use strips, okay, but someone who is lying on his back, his sacrum, his heels, are also experiencing pressure. What's the difference between the prayer posture and the lying posture?
Yeah, thank you. Yeah, in our study, because the study was conducted in the community, we find also the participants who have no problem with the mobility, meaning that they can mobile, but they suffer from pressure injury category 1. It's because of the kind of traditional activity and spiritual activity for praying, for example, that make they should sit for a quite long time, and then also on the knee, sometimes they should sit. Yeah, it's kind of a traditional activity in Indonesia. Yeah, so. It make maybe they don't realize that it's kind of pressure injury category 1. When we measure it, when we conducted the study, that's why in our publication we also educate people, especially in Indonesia. They should aware about the problem. If you sit for a long time and the same position, even though you have a mobility capacity, so it should be.
Sheizi Prista Sari, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. So I request that you and your company await the results of our deliberations and our return in this room.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes. In the meantime, let's take a closer look at Maastricht University's renowned teaching method, problem-based learning. Once the pro-rector reconvenes the session, we'll tune in and continue the live stream.
I like that. You did very good. You were very composed, you were very polite, you were very kind. Together. I thought the last question was quite funny. I was thinking...
Problem-based learning, or PBL. What does that mean exactly? 3 of my fellow students and I will show you around. Every week, we analyze a different case or issue together. We discuss the case and everyone can contribute different perspectives to the group discussion. If we get stuck, our tutor helps us out and suggests what we could do next. I prefer going to the library to prepare. Here, I can focus and I have quick access to books or journals that help me understand the case. Today, I can also train my stitching skills in the Skills Lab, where you can immediately put into practice what you've learned. After a day like this, I like going to the gym to clear my head and get ready for the next day.
At UM, you meet people from all around the world. Hello guys. Some of them are doing their exchange semester here, and they often say that PBL helps them learn and retain things very easily. I can understand why. It's a very active way of learning because you have to bring your own perspective to real-life cases. You have a lot of freedom to manage your time, your studies, your hobbies, and your work. Of course, that also means a lot of responsibility. Right now, for example, I'm arranging my exchange semester in Madrid. How cool is that? In this group session, we're the managers who have to allocate the resources of a real company. This is how we put into practice what we learned this morning. Studying here means being proactive and learning to plan well. Prioritizing and performing well under stress are great skills that help you develop as a person. But now, it's time to grab a coffee at the Student Service Center.
Right now, we're at the Prevalence Camelot campus. Here we can apply knowledge from lectures and tutorials in a practical setting. This helps us understand what we have learned and further develop our lab skills. Today, we're determining the amounts of cholesterol in various products. What I really like is the project periods at the end of each semester, where we complete a full research project that includes planning, collecting data, analyzing, and presenting the findings. That way we learn how research works and we're able to see what it's like to be a real scientist. After practicals, I have to write a lab report that also helps me process everything I have learned today. UM has a lot of learning spaces where you can work on your own or with other students. This evening, I'm meeting my friends for a movie night organized by the MSP Study Association.
If you study law, you have to read quite a lot. Not all information is relevant, so you learn how to easily find the information you need to solve your case. In the afternoon, I have to give a presentation, so I like to practice it with a fellow student. Later today, a lawyer is giving a lecture. This will help us better understand the case we're working on. Speaking in front of a group is quite exciting the first time round, but you get used to it quickly. And having to present helps you also to adopt knowledge better. What I like the most is that we sometimes get to enter a plea in front of a real judge. These moot courts are really exciting. Now it's time for drinks with friends. Studying is important, but so is relaxing once in a while.
Sheizi Prista Sari. The degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict, and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Scholz is authorized to confer upon you this academic distinction in accordance with the Dutch university custom. I invite your supervisor to take now the floor.
Please, all rise.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible? By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Sheizi Prista Sari, the degree of doctor, and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary and the other members of the committee, and affixed with the official seal of the university.
Please turn on the microphone.
Or in English, congratulations with this incredible achievement. The 17th of October will be a day you are never going to forget. I speak on behalf of the whole team when I say that we are all so proud of you achieving your PhD today. It was a delight to see your development in the last years. I would like to go back with you to January 2017, when we received an email of one of our former doctoral students of Maastricht University, sitting next to me, Dr. Fitri Amir. She achieved to successfully finish her PhD trajectory under the supervision of Professor Jos Scholz, Professor Christa Loorman, and Dr. Ruud Halvens, also here today, and graduated in 2015. You and Fitri knew each other since elementary school and shared a passion in nursing care. In her email, Fitri wrote, "I hope someday there will be other Indonesian PhD students working in my previous office. It is one of my New Year's wishes. My friend, Sheizi, a nursing lecturer at the Faculty of Nursing in Padjadjaran University, would like to do her doctoral program about elderly nursing care in the community setting in Indonesia. I think her knowledge and skills will flourish under your supervision. Would you like to be your PhD supervisors?" Soon you received a positive answer, and after arranging the Dicty scholarship, you came to Maastricht together with your husband Harris in the beginning of 2018. You started working at our department, the Department of Health Services Research. Next to that, you became part of the Maastricht Graz Bern doctoral program, which enabled you to learn and exchange knowledge with an international group of PhD students. This also resulted in visits to Graz and Bern during your PhD phase. At the moment you moved from Bandung to Maastricht, you already showed us to be an independent researcher and to be very proactive, because you came here with a database with data on 325 community-dwelling older adults. You and your colleagues visited these older adults to make an inventory of pressure injuries, the ulcer characteristics and background characteristics of these older adults. You did this guided by the LPZ instrument, which is developed at Maastricht University. At that moment, writing in academic English language was still a struggle for you, but you quickly subscribed for an academic language course to improve your skills. Soon, your first manuscript was submitted and accepted, and not unimportant to mention, it was immediately accepted without any revisions, something most researchers never achieve in their lives. And to make it even more special, this also happened to your second manuscript. You also quickly presented your findings at one of our your first international conference, which is the European Doctoral Conference in Nursing Science, a conference organized by PhD students and for PhD students. Soon after your first manuscript was accepted, you brought us some joyful news. You were pregnant. I remember you saying this was a present for you and your husband. Your pregnancy seemed to be a lot more difficult than having your first manuscript accepted. Still, after 9 months, you gave birth to a wonderful daughter, Mariam. You and your husband were over the moon, and soon after giving birth, you also moved to a very nice family house in Maastricht. I visit you now and then in your house. Our meetings took place at the office, but sometimes we decided to do it at your place because it was more convenient with little Mariam around you. I say that was the main reason, but I have to admit, Sheizi, and I know you know this as well, this was not a punishment for me, because every time I visit you, you prepared a table filled with the most delicious Indonesian food. When I told my husband in the mornings that I had a meeting with you, he always asked me with envy, "Oh, you're going to have a good lunch today?" But he knew that you would always also pack something for him and the children. In the end of 2019, you went back to Indonesia to collect data for new studies and to have your family meet your beautiful daughter. I also booked a ticket for April 2020 to visit you, join you in data collection and give presentations at your university. But we all know what happened in April 2020. Corona paralyzed the world and I wasn't able to travel to your beloved country. But therefore, up till now, we still have to plan this visit. Throughout the years you worked as a PhD student, you showed a lot of progression in your academic skills. Your English and academic writing improved, and you also showed to be able to apply different methodologies. If you felt you were not sufficiently skilled to write or perform certain statistics, you subscribed to a course to learn this. This will to learn more and develop yourself is something that really characterizes you as an individual. As we can read in your thesis, you performed both qualitative and quantitative data collection methods and applied a variety of data analysis techniques. And this resulted in a beautiful thesis with 5 high-quality studies. Next to that, you also showed us, also here today, that you were able to present yourself. When you were living and working in Maastricht, life in Indonesia continued, and sometimes you struggled with the distance to your family, especially because some serious events happened. Your aunt, who you regard as your second mom, was hospitalized with a serious fracture, and from a distance you were arranging your former nursing students to take care of her. Because of the time difference, this meant that you were literally busy during the day and the night. And this is actually a striking example of Indonesian culture, helping and taking care of your family even when not around. In your presentation, you also touched upon the fact that in the last months they were particularly difficult for you because of the illness of your brother. You wanted to fly back, but your brother urged you to stay here and first get your PhD degree. You can regard today definitely as a tribute to him, but also to your parents, who always strongly encouraged you to continue learning and developing. And now you stand here today, Sheizi, holding a PhD. And what's next? Within a month, you will go to Dubai for a pilgrimage together with your husband and daughter. And thereafter, you will return home to Bandung, where hopefully you can work on the recommendations of your thesis, such as strengthening the role of community nurses and informal caregivers, as well as strengthening regulations that make pressure injury prevention a priority program. I'm also sure you will continue performing research, and you also talked about your interest of applying the living lab model in Indonesia. So I'm sure we will stay in touch and we will hear much more of you. Sheizi, it was a delight to be one of your supervisors, and I will finish this speech with some words in your mother language that your co-supervisor Fitri helped me with. So, Yang tersayang Sheizi, kamu adalah contoh yang bagus bagi kita. Selamat untukmu, Haris, suamimu, dan Mariam, anakmu. Thank you.
Dear Dr. Sari, also on behalf of Maastricht University, I would like to congratulate you with the degree you have acquired, and I've heard a lot of positive remarks regarding your important work the thesis, and the defense. So I think you should really be proud for all of your achievements so far. At least Maastricht University is proud of you and wishes you all the success in your future career. I would like to thank the members of the degree committee for being here, asking the questions. I would like to thank the people in the audience for attending on-site this session and supporting Dr. Sari, and a special word of thanks to the Indonesian embassy that are here now. I would like to ask you, when I close this session, to leave the room, to move to the reception already, to give us the opportunity to make a picture with the new doctor, and also the opponent who is on-site, online here in the room. Well, I close the session. We will make a picture in front, then Jan can also be on